One, we are live. Please start.
Good evening, friends. Welcome to the PG track program of the Delhi CSI, and we are into the 84th edition of the PG track program. And today we'll be discussing about the approach, stepwise approach to the cyanotic congenital heart disease. As you know, that no cardiology curriculum is complete without having a deeper understanding of the congenital heart disease. And cyanotic congenital heart disease forms the baseline, the bone of the backbone of the clinical examination in pediatric cardiology and even adult congenital heart disease. And this is a very important exam topic also, and very important for practical purposes also. Often we are stuck up in the differentials, how to approach this, and we start mingling the diagnosis, not understanding the basic physiology. So it's with great pleasure, that we have our brother, our very, very dear friend, our mentor, Dr. Ramakrishanan sir, who has been there with us on this journey very regularly. And he has very kindly consented to discuss all the details, the nuances, the intricacies, and how to approach cyanotic congenital heart disease stepwise. So let me tell you, this is like going to be a golden mantra class for you all in the part one. We'll be discussing the details of all these topics. In case you have any questions, clarifications, or any doubts, please write to us in the chat box. We'll be happy to answer them. In case you have any queries, you want to write us on email, pgtrackcsiddelibranch@gmail.com. You can write us, or you can visit these lectures on the YouTube. And on this journey, we have our dear friend, Dr. Sumod Kurian, cardiologist from G. Pant Hospital, Professor Girish MP from G. Pant Hospital, and our dear friend, Dr. Nitish Nayak, who is Secretary of the Delhi CSI. So with great, joy, I welcome Dr. Ramakrishnan, sir, for kindly agreeing. And sir, it's all yours now. Please go ahead and start. You can enable your screen share. Thank you so much for joining.
Thank you, Dr. Mohit. I think it's always a pleasure to be here. And whatever little we have been taught by the various seniors, I think we are able to pass it on. I think I've been very fortunate to be taught by some of the greatest people in congenital heart disease, like starting from Dr. Tandon and Dr. Kothari and Dr. Anita Saxena. So I think most of these that we are going to talk are years of experience of seeing a lot of adults, unoperated adults with congenital heart disease. And the major problem is that most of this information is now no longer available in the classic standard textbooks anymore, because these are some problems that we face in our country. And many of you may think that I'm going to do coronary angioplasty and earn my living, so why should I be tested in cyanotic congenital heart disease? As in clinical medicine, I think oftentimes a lot of areas are gray. Like even in coronary artery disease, a lot of areas are gray, and they cannot be adequately tested with case examples or angiography examples. But then these things actually test you as a doctor, how much weightage you give to a particular finding, how much weightage you give to how do you assess a patient in total. All those things can be well assessed in valvular heart disease and congenital heart disease. So I think compared to valvular heart disease, congenital heart disease, the importance of auscultation is relatively limited. But yet you find in the exams, you find often what is going to be there. If a cyanotic congenital heart disease guy is there, you are likely to have one single second sound and some murmur, one or two murmurs, maximum no murmurs or one murmur or soft murmur, and rarely some continuous murmur. That's all going to be there. So in terms of auscultation, there is hardly anything. You cannot stump. Like you are here, you have the second generation great examiners like Sumod, Girish, and Mohit. So you ask them, many a times you all fumble when it comes to examination of a cyanotic congenital heart disease in adults especially. So I would like to make it as simple as possible. In fact, I would have made it oversimplified. Most of my teachers would have felt this is kind of a spoon feeding, which is just not allowed in DM curriculum. But unfortunately, you don't have books to read nowadays. All those books are gone. So possibly this is a very important thing, which I think will be very useful for your exam preparation. Not only that, I think in terms of overall keeping things clear, the basic bottom line is your thought process has to be clear. So what are the diseases that you're likely to encounter in an adult? When an adult comes to you, number 1, TOF. Number 2, TOF. Number 3, TOF. So even if you write 10, the 10 possibilities, 9 will be TOF. So 90% of the adults that are going to come to you will be TOF. So it's going to be, everything is going to be TOF in by sheer numbers. But some other things are, because you are going to be in a tertiary care institutions, we are all in a place where I think we find a lot of patients coming. So we do find some lot of other patients like. So what are the other patients that we are likely to encounter? Some of the variants of tetralogy, like TOF with the kind of VSD with pulmonary atresia. So I think some of the classical congenital examiners, they don't like the word TOF with pulmonary atresia. TOF is TOF, and if it is a pulmonary atresia like tetralogy, we should call it VSD with pulmonary atresia, because pulmonary atresia has two types: VSD with pulmonary atresia and intact septum with pulmonary atresia. So it's better to call it VSD with pulmonary atresia. Or you can have rarely what is known as trialogy of fallot, that is PS with ASD. And some rare forms, like very, very rarely you will find a patient with TOF with absent pulmonary valve. So these are the TOF physiologies that you have. And then various other forms of TOF physiology that we will be coming to later. The other forms you will find. So then you have Eisenmenger syndrome. Then you have the other miscellaneous ones, most commonly Epstein's anomaly. Very rarely other things like things can be there. And rarely nowadays you don't find, some of the DNB centers can't find a patient who has unoperated Eisenmenger and unoperated tetralogy. So they often keep some operated patients, post Glenn, post Fontaine, who has gone for come for a pre-Fontaine evaluation. All those patients are being kept. So the diseases that you are likely to encounter, if it's an unoperated adult, for all practical purpose, make a note of it. It is going to be some form of tetralogy, if not some 2Es, that is Eisenmenger syndromes and Epstein's anomaly. So these are the likely possibility in any patient who has come to you, any adults who has come to you and sitting in front of you 99% of times. So we'll go into the details of each one of them. So before that, can you mentally answer this question? What is the commonest cyanotic heart disease at birth? Is it tetralogy of fallot? Is it transposition of great arteries? Is it total anomalous pulmonary venous drainage, or single ventricle physiology? Some forms of single ventricle, like some DALV, something. So what is the commonest cyanotic heart disease at birth? So the guess, many would think that it could be tetralogy of fallot, and it is not. So the commonest cyanotic heart disease at birth is transposition of great arteries. So this is the relative incidence of this is cyanosis at birth. So these are the relative incidences. Look at this. So most commonly is transposition of great arteries. Then comes hypoplastic left heart. Then comes tetralogy of fallot. But look at the proportion who are able to survive. So 80% of transposition physiology are going to die within 1 year. Total anomalous pulmonary venous connection is further worse. Hypoplastic left heart syndrome is further worse. Only 10% make it. And pulmonary atresia, only 30% make it, even though you may see some people with pulmonary atresia. If you look at cyanosis at birth, tetralogy of fallot versus pulmonary atresia, this is only a 0.808% difference is there. But you look at it, the survival wise, it is completely reverse. So that is why even this is at 1 year. If you extrapolate it to 10 years and 20 years, only tetralogy survive and rest of them all die. So the most important thing to remember is that transposition of great artery is the most common cause of cyanosis at birth, number one. Number two, 90% of HLHS, around 85% of total anomalous pulmonary venous connection, and 80% of TGA die. Whereas tetralogy of fallot, 1 year survival amounts to around 70%. So another way of looking at it is cyanosis in adults that you are commonly encountering. So you can divide it into 3 types, like common defects with expected survival. So they are going to be TOF and Eisenmenger syndrome. Whereas uncommon defects with expected survival, they are going to be Epstein's anomaly and PS with ASD. So most often than not, PS with ASD presents at that age only. So TOF, we know like it can present at any age, literally. We'll come to the details later. Eisenmenger syndrome commonly becomes symptomatic in the 2nd decade to 4th decade of life, depending on the underlying etiology. And uncommon defects with expected survival, Epstein's anomaly, all of you know that it has a bimodal distribution. So commonly the patients present with the severest forms of Epstein present in the neonatal age group, and then they somehow become better. Those who have to die, those who have extreme forms of Epstein, they die, and rest of them make it, and then they have a reasonably better time when their effort tolerance is good. Then they later on become more symptomatic at around second decade or so. PS with AST, the PS gets progressively tighter and tighter, and generally they present with symptoms in adulthood is not uncommon. Whereas uncommon defects in which adult survival is exceptional will include TAPVC, DORV, transposition of great vessels, truncus arteriosus, and univentricular, other forms of univentricular heart, out of which tricuspid atresia will be one of the very common ones. Relatively, you will find in all high volume centers, you will find tricuspid atresia VSD PS who are unoperated coming in adulthood. But having said that, if you look at the older survival that is reported, like look at this, unoperated, these are all unoperated, like single ventricle, 59-year-old, TOF, 64, truncus arteriosus is 52 years, TAPVC unoperated is 66 years, and look at CCTGA, it is 91 years, and TGA unoperated is 56 years. So even then, rare forms in rare diseases, I think such adult survivals are well known. Maybe some of them, some other case report would have come. I haven't checked for last 1 or 2 years. So some other case report would have come, and I think further it would have extended. But many of them are in the 60s, the 50s and 60s. So these are the basic funda that you have to have before you go to the real approach to an adult who is sitting in front of you with a cyanotic congenital heart disease. So 27-year-old male with cyanotic congenital heart disease given in the exam. So what are the possibilities? So as I told you, some TOF physiology, Eisenmenger syndrome or TOF variants, Eisenmenger syndrome and Epstein anomaly, and it can be rarely others. So the $1 million question that is going to come is whether it is tetralogy or is it Eisenmenger syndrome. So how do you differentiate it from history? How do you differentiate it? This is a common question at the end of history, like patient is complaining of cyanosis. So how do you differentiate whether it is tetralogy or is it Eisenmenger syndrome? So what are the most important pointers that you are going to look at in the history is cyanosis. Yes, present or not. How severe is the cyanosis? What is the onset of cyanosis and how it is progressed? And is there any history of spells? And is there any history of squatting? So history of spells definitely will put the whole money on tetralogy like physiology. Whereas squatting, mostly it is tetralogy, but some of the Indian series have reported around 10% of patients with Eisenmenger syndrome also report squatting or squatting-like postures. So we'll go into the details of the onset of cyanosis and other things in tetralogy. So commonly, very simple, broad terms, like cyanosis in tetralogy is often variable. Like it can be a pink tetralogy, at the extreme extent, it can be really a blue tetralogy who is really saturating very low and he cannot even take few steps. Compared to that, Eisenmenger syndrome generally has mild cyanosis. So this is something that you have to remember, because oftentimes clinical findings can also be overlapping between the two, and examiners don't like you keeping a differential diagnosis of both. Like, so you can't keep a differential diagnosis in general of tetralogy and Eisenmenger in the same patient after your auscultation, after your examination. But remember that you have to take a most important thing is the onset, the course of cyanosis, the degree of cyanosis. Generally, Eisenmenger syndrome, the cyanosis is mild. And most importantly, heart size is normal in both of them. S2 is single in tetralogy, and palpable P2 is never found in tetralogy, but Eisenmenger can have a palpable P2. And there are, when we say never in clinical examination, there will be always some exceptions. In some other variants, it can be found. S2 will be single in tetralogy, whereas in Eisenmenger syndrome, it will be variable. Thrill may be present in Eisenmenger syndrome because it is only a flow-related murmur has to be there. Just think of the physiology. Only the flow-related murmur is going to be there. So you don't find a loud murmur. And you can have a ejection, generally a 2/6 murmur, systolic murmur is what you find in Eisenmenger. You can have an EDM of PR. So X-ray will differentiate between both the things. But I think I will cover the X-ray and ECG and all in the next part. So I think the most important, the fundamental difference is going to be on the degree of cyanosis between Eisenmenger and tetralogy. And the various other findings can be overlapping. But if you find a palpable P2 where you don't find another variant of tetralogy, then you should always think of Eisenmenger syndrome. And by and large, Eisenmenger syndrome do not have a prolonged murmur or a late peaking murmur, or will not have generally a thrill. So this is something that fundamentally you cannot make an error in this. So that is why I think I'm going to cover them everything again in tetralogy and Eisenmenger syndrome, but I want to put it in a nutshell here. And these are some basic mistakes that you should not afford to do. If a patient is very blue, you may find in Eisenmenger syndrome, but really think of it, this has to be why this is not tetralogy. And if you find a good thrill, generally it is not suggestive of Eisenmenger syndrome. You find a very loud murmur, very late peaking murmur, always think of some other differential diagnosis. But on the other hand, if you find a palpable P2, always be wary of diagnosing anything other than a PH situation. So these are the X-rays that I think I will be covering in detail. So the first and foremost thing that you are going to ask from the history is when the symptoms started. First of all, cyanosis when it started in a cyanotic heart disease patient, and signs and symptoms of heart failure. So how are you going to ask those symptoms? Is a typical failure to thrive, sucrus, cycle, sweating on the forehead, difficulty in feeding, all those things you are going to ask. So depending on the heart failure, the onset of timing of heart failure in any congenital heart disease, this applies to both cyanotic as well as acyanotic lesions. So this is the standard teaching when the onset of heart failure in congenital heart disease. Suppose if somebody gives you a history of heart failure, depending on the symptoms and suggestive of heart failure, you can actually make a choice. What is it likely to be? So if it is birth to 72 hours, it has to be like, for example, this cannot be a shunt lesion. That is why this question is repeatedly asked. If there is a heart failure, generally heart failure in a shunt lesion develops after 4 to 6 weeks of life. Because by the time PVRA is very high and PVRA reduces, then only the shunt starts to flow. So if there is heart failure, that means shunt has to be large. Only when the patient has a large shunt, then only the heart failure sets in, by and large. So if it is a heart failure happening, it has to be either a mitral valve lesion or a pulmonary stenosis or pulmonary valve lesions, aortic atresia or critical stenosis has to be there. Whereas if it is 4 days to 1 week, it is generally the hypoplastic left heart and right heart syndrome. Remember this, hypoplastic left heart syndrome is classical, like patient is all right, patient is discharged home, the neonate is looked like normal neonate and is discharged home, and he comes back crashing at 1 week. The most common diagnosis is HLHS. Remember that prototype. So this is what HLHS, how HLHS presents. So generally transpositions can present at any time with heart failure. So then you have the endocardial cushion defects, and coarctation generally presents around 1 week to 1 month. So most of these VSD, PDA, TAPVCs, all of them present to you from onset of symptoms, heart failure from 1 to 2 months. Whereas aortic stenosis can present at any time, but generally, if it is not a very critical AS, generally starts presenting beyond the neonatal period. But same way coarctation, even though coarctation can present earlier also. But this is a very important slide for you to remember that this is the time of onset of cyanosis. So when the first thing I talked about is a heart failure, when heart failure starts in a child. Depending on the history, if you find a cyanosis started at birth, means you're thinking of real critical lesions like TGA, pulmonary atresia, critical tetralogies, obstructed TAPVCs, HLHS, and Epstein. Then you go back to the previous one. So there we are talking about heart failure. That is why TOF did not arise. So 1 week to 2 months, again, TGA and pulmonary atresia are the two common ones. You can have TOF and TAPVC there, and HLHS can present after a week. But beyond that, TOF is the one that remains. And then you have, in the few months to few years, you can have TAPVC, balance physiologies and truncus that remains. And beyond 1 decade, it's all, I told you, like we have been discussing this, Toff, Eisenmenger, Epstein's, and some balance physiologies can be there. And beyond 3 decades and 4th decade, the things that come out, likely to come out are cyanosis, onset of cyanosis at around 3rd decade are likely to be Toff, some forms of Eisenmenger syndrome, like most commonly ASD, CCTG, VSD, PS, and single ventricle PS, they all can become cyanosis at around 3rd decade of life. So let me reiterate again. So anybody neonate comes to you with cyanosis, the most common 2 differential diagnosis that you're looking at is TGA and pulmonary atresia, either intact septum pulmonary atresia or a VSD pulmonary atresia. We are looking at something where pulmonary blood flow is severely compromised. So either it's a pulmonary atresia, intact septum, or a VSD pulmonary atresia, or a PDA dependent circulation is going on, or it can be critical tetralogy. Or you think of other things like neonatal Epstein's, obstructed TAPVC, and HLHS. These are the 3 other common conditions that you encounter in a large volume center. But most common 2 things are TGA and pulmonary atresia. The same thing remains, but beyond 1st decade, everything is tetralogy, Eisenmenger and Epstein's, and rarely you can find some balanced physiologies. And beyond 3rd decade, onset of cyanosis is generally true for Toff, ASD, Eisenmenger commonly, or some rare forms of VSD, Eisenmenger can also start having cyanosis around 25 years of age. CCTG, VSD, PS, and single ventricle PS. So other specific history features that suggest to you include, as I told you, like age-at cyanosis, and is there a history of heart failure is there or not? So heart failure history, I think all of you know this part, but again, I reiterate, heart failure can be because of 2 reasons. 1, the patient had a cyanotic congenital heart disease that can produce heart failure in the early infancy, like for example, a truncus arteriosus, which later on become Eisenmenger syndrome, or has a lesion that is persistently more than 2:1 shunt, like for example, a TAPVC, which has heart failure in the infancy, but it's very uncommon. Like somebody like TGA or TAPVC develops heart failure in infancy. Generally, they don't make it, they die. So heart failure, either heart failure in infancy with cyanosis, with expected survival in adulthood, generally it is truncus arteriosus or some balanced physiologies. So we are looking at actually CCHD increased QP. If there is cyanosis in the neonate as well as heart failure, we are looking at some of the conditions, we call it CCHD with increased QP. Or if you have, initially there was no cyanosis, but there was heart failure. Later on, heart failure disappeared, and later on, cyanosis came up. So that is a very classical history of all common Eisenmenger syndromes like VSD Eisenmenger syndrome or even PD Eisenmenger syndrome. You can have this classical history. Patient had failure to thrive in infancy. Patient had success cycle, and patient developed cyanosis later. And if there is history of failure to thrive, almost it goes in hand with heart failure. You should remember the increased QP. Cyanosis is the increased QP, or some syndromes that can produce some syndromic children can have failure to thrive. And one more important reason in adult cardiology you should remember is patients can present with Toff with absent pulmonary valve. So patient has hemoptysis, history of hemoptysis that can be attributable to both tetralogy of fallot as well as Eisenmenger syndrome. This is very common. Patient has tachycardia-like palpitation. So it's very simple. Remember this: Epstein's anomaly, AV canal defect, and CCTG. All of them are associated, known to be associated with bypass tract. Even heterotaxy syndromes are all known to be associated with bypass tracts. So these are the conditions that you should think of. Patient comes to you with palpitation, which is tachycardia-like palpitation, episodic palpitation. So you should think of these differential diagnoses. And in syncope can have commonly in PS with intact septum, or rarely you can have syncopes in tetralogy and Eisenmenger syndrome. But AV blocks, if you're thinking of AV blocks, again, the common ones are AV canal defect, CCTGA, and heterotaxy syndromes. So these 3 things remain like cause of both AV block as well as tachycardia palpitation, whereas Epstein gets added to a common cause of palpitation. Is it clear? These are the specific history features that suggest your diagnosis. So what is the age at cyanosis and what is the course of cyanosis? And then we'll go into the details later. And is there any heart failure present or there or not? And failure to thrive, if it is there, you think of increased QP and syndromes as well as TOF with absent pulmonary valve. Hemoptysis generally indicates TOF and Eisenmenger syndrome. If there is thinking in terms of a tachycardia palpitation, you should think of Epstein's AV canal defect, CCTG, and heterotaxy syndromes. And if it is syncope, it is PS, most commonly intact septum. Rarely you can find it both in tetralogies as well as Eisenmenger syndrome. Whereas AV blocks is the same like AVSD, CCTG, and heterotaxy syndrome. So this is the amount of thing that you can go. Like, for example, if there is a history of spells, if there is history of squatting, so these are the history that you can get. You can't get anything more than this, and you can get the history about the consequences of cyanosis in an adult, which we'll be discussing later in the next part. So now we go to the most common condition that we are likely to encounter, that is TOF physiology. How do you approach a TOF physiology? So TOF physiology. So what is its TOF physiology? Characteristic feature of any TOF-like condition is has an unrestricted VSD and has pulmonary stenosis, and that causes central cyanosis. So they are grouped under CCHD with decreased pulmonary blood flow. And they have a physiology of right to left shunting at ventricular or aortic level. So history of cyanosis at rest or crying or inactivity. So always in your exam, before you call somebody as a pink tetralogy, always ask them to exercise, because if you think of a pink tetralogy, a guy who's pink, I think there is no harm in exercising the patient unless he is in gross heart failure. Then you are not considering tetralogy. If you are labeling somebody as pink tetralogy, always do an exercise saturation. In any congenital heart disease, you should better do an exercise saturation of all 4 limbs. So this is one important thing that you should remember. Is 25% are cyanotic at birth, whereas 75% are cyanotic by 1 year of age. So commonly asked question is, why do tetralogists develop cyanosis later? Why they are not all of them are cyanotic at birth? That is because the child outgrows the amount of pulmonary blood flow. The child progressive increase in oxygen demand of the growing child. And generally there is increasing PS that happens. And there is after birth, there is a slow change from hemoglobin F to hemoglobin A, which is a better carrier of oxygen than the latter one. By and large, they don't have failure to thrive, and they have generally normal growth and weight gain. So squatting generally is actually considered a very important feature of an adult with tetralogy. So there are how squatting relieves symptoms. We all know that. So SVR increases and diverts the RB blood into PA so that the pulmonary blood flow increases. More importantly, squatting decreases the venous return from the leg, which has the lowest oxygen concentration, saturation. As I told you, like 3 to 10% of Eisenmenger syndrome may also in our series also reported a history of squatting. And there are some squatting equivalent that are described. They are sitting with legs drawn downwards, legs crossed while standing, mother holding the infants and legs flexed upon, and lying down position are all can be considered a squatting equivalent. So cyanotic spell is again another important feature that tells you about whether it is a tetralogy or not. I think it's a more important history than even history of squatting to differentiate it from Eisenmenger syndrome or some other form. So you get a history of spell. You are often assured that this is going to be, you are dealing with something like tetralogy or tetralogy-like physiology. If you find the squatting, generally it is mostly tetralogy-like physiology, and rarely it can be Eisenmenger syndrome. So you take away everything else like Epstein, this, that, everything else is taken out. So it's going to be very simple. Keep it very simple. Like you concentrate on when the cyanosis started, how it progressed, and what is the current status now. And if there is a history of heart failure, history of failure to thrive is there or not, if there is history of squatting and history of spell is there or not, with this, you will be able to make up your mind what is going to be the diagnosis. Most often than not, you will be always right. Rather than relying on some exotic finding about finding this murmur, finding this, those don't help. Like. So what is the mechanism of spell? So unfortunately, none of the mechanisms can explain all the known features of spell. Like for example, so most commonly we think that infundibular spasm is the cause of spell. So that is known as Wood's theory. So whenever the patient cries, the catecholamine increases, all those things happen, the contractility increases, and that increases infundibulum narrowing. So the point against that is like, so there are spells that happen in pulmonary atresia situation. So there is no pulmonary valve, there is pulmonary atresia. Still the patient develops cyanosis and cyanotic spell. So we all have seen, I think anybody who has practiced pediatric cardiology have seen any number of pulmonary atresia patient coming with spell. So this explanation alone cannot explain this. So then there is another important feature of spell is generally it occurs in 6 months, and then beyond 2 years it just generally vanishes. Beyond 2 years it's uncommon to find a spelling child. Why that happens? That also has explanation. Many people think that possibly people who have to die, but we have seen enough number of patients who had been spelling, but then they couldn't get the surgery done, but still they are alive, but then the spells have disappeared. So something else is happening. We don't know. So some of the things that are there are like simple, just the mismatch between the amount of blood going into the lungs and the amount of blood going into the system can actually produce a spell-like situation. But there are another important theories have been like paroxysmal hypopnea or mechanoreceptors in RV by Dr. Kothari, and vulnerable respiratory center. That I think can explain in part why that spells disappear after 2 years. Once you dig deep into all this, so you never fumble when you are asked like, what are the mechanisms of spell? Like, so you will immediately come up with various answers. Like, and then Young proposed that it could solve because of atrial tachycardia. But we have monitored patients, so that's very rarely atrial tachycardia can precipitate a spell, but not vice versa. That every spell is not due to atrial tachycardia. So there are various mechanisms of spells. The bottom line is we don't understand the real reason for spell, but spell definitely indicates it's a tetralogy or tetralogy-like physiology. So what are the common findings? I told you about the futures. Futures are very simple. Cyanosis, majority are not cyanotic at birth. 75% are cyanotic at 1 year of age. So neonatal cyanosis 25%, infantile cyanosis is 75%. So remember it 1/4 and 3/4. So now they have normal weight gain, normal no chest infection, nothing. They are otherwise normal good, and they can have squatting and they have cyanotic spells. Cyanotic spells in till 2 years of age and squatting beyond that age. What are the common findings that you find in a tetralogy-like physiology? This is very simple. There is nothing. There is literally nothing. If you find anything significant, then it is likely to be not tetralogy. So what I mean, generally JVP is usually normal. You can have a prominent A wave in adults. Normal cardiac size, no heart failure. If there is cardiomegaly, think of something else. If there is heart failure, think of something associated. No parasternal heave or 1/3 heave at best. Systolic thrill is uncommon. S2 is single. Ejection systolic murmur is there, and it is generally a soft murmur, 2/6, with a peaking which is in early or mid part of systole. And murmur is inversely proportional to cyanosis. And no S3, no S4. So I told you, what are the common auscultatory finding of tetralogy is nothing. So you go through one by one. The common finding that can happen will be A wave in an adult with tetralogy. The common finding that can happen will be A wave in JVP, a single S2, and a soft murmur. That's all you can have. And the murmur is inversely proportional to cyanosis, meaning by if a patient is very blue, you are likely to find a lesser grade of murmur. If the patient is very blue, if the patient is pink, you are likely to get a thrill and a good murmur. So I think we will have that question in the discussion, like why pink tetralogies are pink. This is another question that anybody, generally majority of the people get stripped. Why pink tetralogies are pink and blue tetralogy is blue? It's a stupid question, but I think this has been asked by the exams many times. So think about this question, then we'll give the answer at the end of the presentation. So now comes at the DM level, we expect, we are not happy if you say that, okay, this is tetralogy of fallow or tetralogy-like physiology. You should make an attempt to differentiate between various other forms of tetralogy-like physiology, including the typical VSD with PS. Not tetralogy, like there could be just a VSD, non-overriding VSD with a valvular PS or a infratubular PS. That is almost impossible to differentiate unless the patient gives you typical history of increased flow during infancy and later on develop something like a Gazul phenomenon, what is called as the infratubular narrowing that happens later on in VSD. If that history is classically found, then you can think of VSD-PS. Otherwise, from examination point of view, from auscultation or clinical examination, you cannot differentiate. At times, it is very difficult to differentiate in echo also between VSD-PS and tetralogy, pink tetralogy, for instance. The other common physiology that you are supposed to differentiate include DVRU VSD-PS, tricuspid atresia VSD-PS, TGA VSD-PS, CCTGA VSD-PS, AVSD-PS, single ventricle PS, and some complex heterotaxy syndromes. Let us go one by one. DVRU VSD-PS is equal to tetralogy of fallow if the great vessels are normally related. So how do you differentiate? How do you define DVRU VSD-PS? How do you define DVRV? Earlier era, we were taught like iotometal discontinuity is everything. If you find an iotometal discontinuity, you call it DVRV. But now many papers have come that you should rely on more on the amount of override. And for example, any tetralogy with greater than 50% override, when this is committed to more towards RV, so then you should call it as a DVRV. So it is just a in a way it is not very different if it is a tetralogy or a DVRV VSD-PS with normally related great vessel, because the management is going to be the same. And except for some changes in ECG, I don't think clinically you can make any differentiation. Whereas tricuspid atresia is a very important, easily you can pick up very easily in the bedside by, yes, somebody said LV apex. So I assume you know this. So it can be TGA VSD-PS or it can be CCTGA VSD-PS, AVSD-PS and single ventricle PS. I will come to each one of them when you think of them. So some hard rules, some hard findings are there which are useful in differentiation. Some soft findings are there which are useful in differentiation. So as I told you, a palpable pulsation in second left intercostal space in a tetralogy like physiology should immediately prompt. You are not thinking in terms of pH. Suppose if there is there, if you think of Eisenmenger syndrome, it's a different possibility. But if it is there, if you're thinking in terms of a classical tetralogy like physiology, you should always think of a pulsation or a palpable second sound there. You should think of an L post aorta. So L post aorta, where I'm keeping my hand in my chest, it is in the second space where you commonly think of the pulmonary area. The aorta is left and anterior and it is lying over there. It's a classical L post aorta. If you find a palpation, you can rarely find the aortic sound palpable there. So if you find a palpation in second aortic space, you should think of CCTGA, L post aorta. So LV impulse is very uncommon, very rare in a patient who is cyanosis. But if you find a LV type of apical impulse, you should think of a tricuspid atresia or a single ventricle type physiology, or two relatively common conditions which are not tetralogy like physiology, because we have been discussing, that's why I put it in brackets. We are talking about tetralogy like physiology, but if you find an LV effects, always think of Epstein's anomaly and in a younger child, pulmonary atresia with intact ventricular septum. One extremely rare cause of LV impulse is a DVRV with restrictive VSD. So DVRV means both the arteries are arising from the right ventricle. So what is the outlet for LV? Outlet for LV is this VSD. That VSD has become restrictive. Now this is behaving like an LVOT obstruction. It's almost behaving like an AS. So you find a concentric LVH and you find a heaving apical impulse. So very rarely you find a heaving LV type apical impulse in a cyanotic congenital heart disease, and there is hardly any other differential diagnosis if you don't want to combine two lesions. For example, a tetralogy with subaortic membrane or some kind of a stupid combination you don't want to make, then the only differential diagnosis is going to be a DVRV with restrictive VSD. Now for those intelligent people who are not so much exposed to cyanotic congenital heart disease, tell me what will happen if the tetralogy VSD gets restrictive? Yes, the right heart fails, the left heart doesn't fail. So in a DVRV with restrictive VSD, the LV pressure becomes suprasystemic, whereas in a tetralogy with restrictive VSD, the RV pressures become suprasystemic. Am I clear? So LV apex in cyanosis for me has 5 commonly encountered conditions. Most commonly it is tricuspid atresia VSD-PS. Yeah, LV form of single ventricles can have this. There is no brainer in that. 2 non-tetralogy like conditions can produce LV apex. Those are Epstein's anomaly and intact septum pulmonary atresia, and one very extreme rare combination of DORV with a restrictive VSD can have LV apex. It's very simple. If you remember it like this, you will never forget in your exams. So one more important thing, one more hard rule is murmur which is out of proportion to cyanosis. The murmur is out of proportion to cyanosis. Commonly quoted is a TGA-like physiology, where I think what is the murmur produced by? Murmur is produced by the degree of obstruction. Like if you find a obstruction, the murmur becomes more in a patient who doesn't have a VSD. So if you find a PS, murmur is directly proportional to the severity. Whereas if you have a VSD, what is the murmur dependent on? Dependent on a good pulmonary blood flow. So whichever patient has a good pulmonary blood flow will have a good murmur, but will not be cyanosed because the pulmonary blood flow is good. It's not too much reduced. Am I clear here? I will come again. If you find a PS, the septum is intact. As severity of PS increases, goes on increasing, murmur goes on increasing. So the murmur is directly proportional. That is not a tetralogy physiology. In a tetralogy physiology, you have a large VSD and there is a tight PS. So what determines the murmur? If the PS becomes very tight, every blood will go through the VSD. Nothing goes through the, it's almost like a critical PS or a foramen-fistulae pulmonary atresia like presentation. So that you won't find a murmur. There is no flow growing across that PS. If you have a very good flowing PS, the flow is very good. So the flow is very good, and then you find no cyanosis because the pulmonary blood flow is very good. Am I clear here? So now comes this paradoxical situation where murmur is out of proportion to cyanosis. Patient is cyanosis all right, but murmur is too good. Why that happens? Because something else is contributing to the cyanosis. Be clear in this. Something else. What is that something else? Is the streaming. Like for example, TGA. Why there is cyanosis? Even if there is TGA VSD PS, murmur is not inversely proportional. So basically, murmur is out of proportion to cyanosis because there is a streaming. That means more deoxygenated blood goes into the system and more oxygenated blood goes into the PA, like a transposition like physiology. So DRV, when there is a some form of unfavorable streaming producing more cyanosis, you find a good murmur and murmur which is out of proportion to cyanosis. Commonly, we don't find a very loud murmur in TGA because of the positioning of the great vessels. Even though their QP is increased, but the positioning of the great vessel is such that you don't find a loud murmur. So I told you these are the important variants. The important ones, they are hard ones. Like if you find a LV apex, your diagnosis has to be one of these 5 in a cyanotic congenital heart disease. If you find a good you are confident about palpation, is very simple, very easy. So if you are in a tetralogy like physiology, if you find a pulsation in second intercostal, you can straightforward say that this is CCTGA VSD PS. But some of the ones which are softer ones, like for example, you find a murmur of AV valve regurgitation, like a mitral regurgitation or tricuspid regurgitation, right side or left side AV valve regurgitation, should think of AV canal defect and character transposition. You find an early diastolic murmur of PR. Either it is an Eisenmenger syndrome with a loud P2, but if you're thinking that it's not a loud P2, you're thinking in terms of a tetralogy physiology with an EDM, should always think of absent pulmonary valve syndrome. Always think of mesocardia, dextrocardia, think of CCTGA first. Complete heart block, always think of CCTGA. And the degree of cyanosis. So generally, for a given lesion, for a given age, The cyanosis is much more in a TGA and a DORV like situation because of unfavorable streaming along with that. And it is commonly less, they are more balanced, more better off in a single ventricle or CCTG physiology. It's not uncommon for us to see a CCTG coming at around 40 years with mild cyanosis only. And some forms of single ventricle also have milder forms of cyanosis. So I think I will finish off briefly the management part of tetralogy like physiology, because many of you are adult people and you may not be conversant with the timing of surgery and how do you approach it. What are the things to look forward? Because various names are given, and individually, if you go on reading them, it becomes a longer time to read. And these are like simple, very simple rules that you have to follow. So definitely single ventricle repair. So for example, most of the heterotaxy syndromes, if there is tricuspid you can't do much. If it's single ventricle physiology, you can't do much. Because only one ventricle is there, one AV valve is not there, you can't do much. But in most of the other conditions, two ventricle repair is possible in a DORV, TGA, CCTGA, AVSD, and very rarely some form of heterotaxy, still two ventricle repair can be possible. So what determines whether in these situations on the left-hand side, what determines whether a patient is suitable for a two ventricle repair or not? So what are the things? First of all, you have to have two adequate ventricles. So if one ventricle is hypoplastic, one AV valve is hypoplastic, you can't go for surgery. So it cannot be having mitral atresia or anything cannot go. The most important key word is whatever repair you do, you should be able to route LV to aorta. And if it is an AVA canal defect, it has to be a balanced defect. So any of these conditions like DORV-VSD-PS, TGA-VSD-PS, if they have two good size ventricle, VSD, which is actually allowing us to route the LV to aorta, and you can have a balanced defect in an AV canal defect, and there is no AV valve hypoplasia and atresia, most of them should be able to go for two pump repair. And today's time, with the advent of various switches, that like apart from the simple full-blown arterial switch, we have the REV, the Nicoido procedure, all those things are there for TGA VSD PS. You should read about them. So there is a various alternative for TGA VSD PS. You should know about that. So coming to the natural history of tetralogy, the survival rate, as I told you, survival of tetralogy. We are not talking about cyanosis in tetralogy. Survival rate in tetralogy is around 65, 50, and 2/3 at 1 year, half at 5 years, and 1/4 at 10 years. This is also not great, but it's a very common lesion. So I think the survival is very good. And trough-like conditions are further poorer. So another important thing is, when should you operate or not? If a patient is relatively asymptomatic or mildly symptomatic. So generally the consensus is that any tetralogy should be operated when biventricular repair is possible in a good center where the surgical mortalities are low. So futures determining the timing of surgery in tetralogy. So need for surgery, whether patient has symptoms and cyanosis or cyanotic spell. In today's time, anybody with cyanotic spells, we often go for total correction if the child is of reasonable age and reasonable weight. Mostly that depends on the various hospital to hospital and various policies. So anybody who has cyanotic spells, we often go for a total corrections if the child is more than 5 kilos at our center. If it is less than 5 kilos, oftentimes we end up doing a BT shunt, or nowadays we do a PDS stenting or an RVOT stenting in the selected patients. And whether the patient in any of these tetralogy like physiology a need for conduit, we generally try to palliate them with BT shunt, and then later on go for a conduit repair later on. And depends on surgical expertise at the individual institutions, and then it determined by AV regurgitation and ventricular function. The simplified algorithm for children will be any top-like physiology where a two ventricle repair is palliative is possible. We generally go for a BT shunt. Generally, most of the centers in India follow a rule of 3 months to 6 months and 2 years to 2 years where they operate, and 1 to 4 years if there is a conduit is required. So before that, we do a palliative BT shunt or a RVOT stenting or a PDS stenting in today's time. So ICR generally 6 months or 5 months, depending on the various institutional policies. And neonatal ICR, I'm not sure that anybody is practicing in India. ICR stands for intracardiac repair. So if it is a conduit needing surgery, by and large, we do for a palliative bed shunt and then go for a conduit later on. If it is a single ventricle pathway, so like single ventricle, like for example, tetralogy. So what are the common single ventricle pathways that you know of where patient undergoes single ventricle correction? Is a tricuspid atresia VSD with PS, a single ventricle with PS, or some of these heterotaxies where DVRV, VSD with one ventricle hypoplastic, a DILV, DVRV with a non-routable aorta, which is far away from the VSD. We cannot route it to the LV. The TGA VSD PS, which cannot be routed to LV, aorta cannot be routed to LV. So mitral atresia. So these are some of the conditions like HLHS, if it is after the Norwood repair. So these are the ones that go for a classical single ventricle pathways. So we are dealing with PS like situations. So we are not talking about PH like situations here because we are talking about tetralogy like situations. So in tetralogy, patient if required, we'll go for a BT shunt or a PDS stenting. Glenn nowadays is done at around 4 months to 6 months of age to 1 year of age. And then Fontan around 3 to 4 years. This is the ideal situations in which it's done. So oftentimes we don't do a BT shunt. Not everybody needs a BT shunt. So if the patient can directly go for a Glenn, or at times Glenn and then rarely Fontan. And rarely we can send a patient from BT shunt to directly to Fontan. So this is the algorithm that we follow in children. That is the timings that have been given. What is the management algorithm in adults? So very rarely, it's extremely rare that we do an palliative repair. If there is a ICR, mostly patients undergo an intracardiac repair. And even if it is conduit needed, most of the adults undergo conduit repair. So very, very extreme rare conditions, we have done palliative repairs. Like, for example, if the PA size is inadequate in a tetralogy or in a pulmonary situations where the PA size is inadequate, or if it is a very, very sick child who underwent an emergency, got intubated, patient borderline PAs, and then very sick situation, we do a central shunt. Remember that BT shunt is extremely difficult to do in an adult with tetralogy because there are a lot of collaterals and a lot of bleeding that happens for the surgeon. And single ventricle pathways, shunt and Glenn rarely have a role because Glenn ability to palliate adult single ventricle pathway with a Glenn is very poor. Like they don't improve with saturation. Even if you do a staged palliation like a Glenn and a Fontan, it has to be done very quickly. Like for example, you do a Glenn, not much improvement happens in saturation by and large, and then within 2 months you have to convert it into a Fontan. So oftentimes primary Fontan, if in a selected patients who are good for Fontan, should be the treatment of choice. So this is about a brief about the TOF and TOF physiology management. So commonly we often, like I told you about the TOF physiology, what are the other types of TOF physiology and how do you identify them and how do you manage them. So now we go to some of the TOF variants. This is a very commonly asked question because this tests your understanding of the physiology. Like this is PS with right to left shunt at atrial level. How is it different from tetralogy? So basically we are looking at PS with intact septum compared to PS with VSD. What are the differences? So intact septum is intact. Whatever load, the RV has to handle it. So there is a dominant A wave in JVP, and if there is a failure, there is a TR, PS with TR, then you have start developing CV waves and all. Because the heart, there is nothing to compensate. There is no VSD to compensate. There is no cardiomegaly in tetralogy. Here, heart size has to increase. There is heart failure that happens because there is no VSD to decompress the right ventricle. The right ventricle forces will be transmitted. You will have a good parasternal impulse. So S2 will depend on the pathology, but mostly you have a valvular PS. The P2 becomes soft and inaudible, and you have a murmur that is very, very long and prolonged, which is proportional to severity, late peaking, and almost engulfs the P2. It ends with P2. Like, so there can be RVS3 and RVS4, and there can be a TR murmur. So in the PS with TR, there can be PR murmur. So this is how do you differentiate. This is the same way you put it across against tetralogy. So normally JVP is normal in tetralogy, whereas it is higher in triology. This was what is known as triology of Fallot earlier. So there is no cardiomegaly in tetralogy. Here it can be cardiomegaly. No parasternal heave in tetralogy. Here there is parasternal heave. Murmur is inversely proportional to severity, whereas here it is directly proportional. You don't find RVS3, S4 in tetralogy, whereas these are very common in PS with intact septum. So the other differential diagnosis, other variants of forms of tetralogy include pulmonary atresia. So in various series, it's in the tertiary care center, it is around 5 to 10% of tetralogy physiology. So commonly they have an onset of cyanosis in infancy. Some of them have, especially in infantile forms, can have heart failure. 1/4 of them can have heart failure due to increased pulmonary blood flow. So continuous murmur of MAPCA or PDA can be there. That is a very important differential diagnosis. How do you differentiate? How do you identify? Because there is no flow, because pulmonary atresia is there. You don't find a parasternal murmur. At the same time, you will find a continuous murmur in the back. So continuous murmur from MAPCA or PDA, these murmurs are maximal over the side of the collateral. So they are heard in the right and left of the sternum. Possibly they can arise from the descending aorta. Posteriorly, mostly posteriorly. RVT murmur is not present. So the rest of the things are same, but oftentimes, like think of it like whenever the pulmonary artery narrows, the aorta and pulmonary artery sizes are inversely proportional. Like whenever the pulmonary artery size is narrow, aorta becomes larger and larger. So as the aorta dilates, you will find an aortic ejection click. So oftentimes when you are presenting in your exams, right case of tetralogy, but you are got into trouble. Many times you will get into trouble. Something will be there that you are not able to explain. But these are some numbers that you can we can help you in tiding over the crisis. Like congestive heart failure is found in around 15% of tetralogy in adults. Hypertension in around 7%. Aortic regurgitation around 7%. ECG may show LVH in 0.7%. Absence of RVH in around 3.4%, and Q wave in lateral leads in 8%. So these are some of the numbers that you can remember. If you are get into trouble, then you can use them to get out. So another commonly asked question is, when do tetralogy develop heart failure? So I think this tetralogies don't have heart failure, no cardiomegaly, no heart failure. The most common reasons are anemia, and most common structural lesion is restrictive VSD. The rest of them are rare, like they include TOF with AR, TOF with PR, TOF with TR, infected endocarditis, ventricular dysfunction, surgical shunts, collaterals, arrhythmias, hypertension, and AS. So possibly this is a kind of order that you should follow. Most often than not, we ask this question, the first thing that comes out from a resident is collaterals. Collaterals are extremely rare for TOF to produce heart failure. So some teasers, I think, for you to read, we'll discuss it later. So I told you about triology versus tetralogy. What are the common syndromes associated with tetralogy? And a lot of examiners are fond of asking this right aortic arch. How often you find right aortic arch in tetralogy, in DRV, in truncus, and all those things. And if you find right aortic arch, how often it is on the other way around? Like if you find that right aortic arch, how often it is pulmonary atresia, how often it is truncus, and all those things. So I think all of you should be aware of catch 22 and what is in this catch. Why you get a boot-shaped heart, and why there is early transition in ECG. And most commonly, I think very importantly, as an adult cardiologist, you should be knowing about the post-tetralogy operative issues. What are the cutoffs for surgery and all those things. And CCHD with continuous murmurs, I think is something that I think you should be reading about. So these are the ones that commonly associated with continuous murmurs. Pulmonary atresia with VSD, TOF with collaterals, or a surgical shunt, TAPVC, pulmonary AVMs, peripheral PS with right to left shunt, and mitral atresia with a restrictive VSD. I think maybe I can stop here. It's 7 o'clock, so we can have the Eisenmenger syndrome covered in the next class. We can have some discussion now.
Yeah, thank you, Dr. Rama. Thank you so much, Subodh and Girish. I think you guys will also be there. Thank you. It's truly as usual, a terrific presentation. It's always a pleasure to hear those, these are very practical exam texts and a very beautifully elucidated, approach to the cyanotic congenital heart disease. Dr. Amma, one of the questions that comes to that often the children, these students are asked about, about the theories of cyanotic spell. So which of these generally they ask that, is most commonly accepted generally? So what would be one be answering? Because none of them, each one has their negative points as well as positive points, and practically none of them is which comes closest to explaining the cyanotic spell.
I think possibly, infundibulous spasm plays a major role in most of the tetralogy, even though that is not by itself sufficient to explain everything. But another important thing is the relative changes in SVR, PVR. And it is better that you start with that the exact mechanism of cyanotic spell is not clearly known, but these are the hypotheses that have been proposed. So I think most of the examiners, and then central hyperpnea as well as hypercapnia, along with the central the overreactivity of the central receptors. These are, I think, good enough to explain the spells in most other cases.
Second thing that I would like to bring forth is one of these sessions we had with Dr. Anita Saxena. I remember very well. And that time, the question that you had asked us, that you just mentioned, was that why there is early transition. So this question was put forward to her, and her answer was very different. You would be definitely aware of that. She said, instead of answering it, that I remember time of Dr. Tandon, and she used to say that this is still not explained. It is all just hypothesis. But you cannot just pass off the exam with this kind of a comment. So what would be your take on that? Though she was very candid in answering that, and they're very typical that monotonous answers for this, which are setters for the exam. So I would like to have your thoughts on that.
I think this is what I think Tandon sir has been teaching, and this is what we have been teaching at AIIMS, that we don't know the reason why there is early transition in tetralogy.
Yeah.
That is the bottom line. I think because why we see so is like, for example, people often say, like, mostly I think a lot of answers came from a lot of South examiners. They are very fond of saying that this is where exactly you will find a V2, there is a big VSD is there.
VSD, yeah, that is right.
But then to counter that, what is there is that you don't find that early transition in just the VSD alone. You find a VSD, a large VSD, which is small length, with the typical tetralogy like VSD, but there is no PS. If this electrical phenomenon is just because of that large VSD, which is overlying that V2 position, then this should be happening there also. It is found only when there is tetralogy, and then it's not found when it is a VSD with PH situation.
Yeah.
The same VSD. If the VSD is causing the electrical phenomenon, it should be the same in both.
So the answer should be that you should be aware of both, and
Aware of both.
Aware of both. That's an easy way of. Dr. Sumud, would you like to carry on? And there are a couple of questions that have also come. Yeah, Sumud.
Yeah, one thing why the spells disappear. Many people has said one reason is that they know how to compensate now by either squatting or those thing we can say. Some people even say that even if you are invoking the vulnerable respiratory center, the center has now matured, and probably that is another reason. Then many times we say infundibular spasm cannot explain because pulmonary atresia, these spells could be of different mechanisms also. Sometimes it could be if there's a PDA dependent, PDA going into restriction or spasm or collaterals closing off. Many other things can explain that, but in the absence of all that also, probably just by the mechanoreceptor stimulating, and that also could be I think the first slide that we saw, I'm just asking whether it is a institutional bias, like if we say which is the most common cyanotic heart disease at birth. Still, I think it should be tetralogy. I think in an institute like AIIMS, most of the cases that
I'm not talking about tetralogy in in institute like AIIMS. This is like birth prevalence, like from I don't think I put the what is the source of reference? A very, very standard reference, like some taken from some textbook, like. So this is not a institutional thing, and I think it is very common. Like TG is fairly common, like.
Yeah, the other thing, whether it will be right to combine triology, physiology along with as a tetralogy variant, because I think Dr. Tendon follows it as a different physiology. He follows it as a PS, AST kind of a triology is a different physiology in his classification, because they're present in a totally different way. So I think it is better to not to consider it as a top variant probably, because we can in Dr. Tendon he has classified into 6 physiologies. So one physiology is where.
So I think Sumant, you are right. Like if you strictly follow the textbooks, and even I think Perloff classifies cyanosis like that. But that classification for an adult becomes obsolete almost for me. So like the classification that is strictly followed, that actually for an adult cardiologist, I don't think that is a very good classification. If I have to teach a pediatric cardiology group of people, I think I will go back to that classification. Because they are unlikely to encounter many of the conditions that are being classified like that fashion, and that produces more confusion than I feel. This is a very simpler way of approaching the VAS. If you find an adult with ASD, it has to be some tetralogy or tetralogy-like physiology, or some other variants of tetralogy, and then Eisenmenger and Epstein. That's all. Period. Full stop. If you know this much, you are good enough to practice in adult cardiology in India. That much is good enough. That is the way I approach it. That's why I made it more simple. You are right. If you are a purist, and even pulmonary atresia cannot be grouped into tetralogy-like variant, they are all very different embryologically and hemodynamically.
No, not embryology. I'm saying clinical presentation wise, because we say spells and squatting are the classical presentation, which will not occur in pulmonary stenosis with ASD. On the other hand, it can occur with pulmonary atresia. So, well, I'm just saying to say this is the hallmark symptoms of this physiology. Then, no, including
they're not
variant becomes
physiology. Like for example, they cannot be clubbed into tetralogy physiology, like because that's why tetralogy and tetralogy like physiology and some other variant forms. That's all.
Yeah. Okay. There are questions that how to differentiate on ECG basis. This we'll be covering next time, Dr. Questions, we'll be having next time. And when will tricuspid atresia present with cyanosis? Dr. Sunil has.
So I think tricuspid atresia VSD-PS generally presents with cyanosis in. It's quite variable. By and large, commonly we see around a few months of age they start coming with cyanosis, and rarely they need a BT shunt also. Or majority of them can be directly gone for a Glenn. So mostly they present around 2 months to 6 months age sinus onset of cyanosis.
Also,
Dr. Rama told, Dr. Rama told he will discuss pink tetralogy in the discussion time. So Dr. Rama wanted to give his, I think that is again another thing like the early transition like question.
That will be next time.
No, we'll just finish it off this question, like why the tetralogy, some tetralogies are pink and why some are blue. So commonly, the commonest answer that I find in across the board, across everywhere is that PS is less severe. So that is the common mistake that every resident commits. Like even the very good residents generally get stripped in that. So then immediately the examiners come and then they start asking, okay, so what will be the PA pressure in pink tetralogy? So it will be 25, sir. Okay, 25. What will be the RV systolic pressure? Sir, it will be 120, sir. Then is the PS severe or not? Yes, sir. PS is severe. Then what are you saying? So this is the kind of language and the monologue that happens. Like it's almost a monologue because resident is first gaya bekaraga. So the answer should be like it depends on the pulmonary blood flow. So which is determined by, to me, I think it's determined by a lot of factors. Like it's not about just the severity of PS is one thing, but I think everybody has severe PS. Like remember this way, even the pink tetralogy has severe PS, as well as if you say this is a tetralogy physiology, means there is unrestricted VSD and severe pulmonary stenosis. Period. Either infundibulum or valvular PS is there. But it determines by the pulmonary blood flow. The severity of obstruction and pulmonary blood flow is a complex interplay. It depends on so many things, like, for example, the cross-sectional area that is available. Then it depends on the relative size of PS. It is determined by the relative PVRI and SVRI. And it is determined by even the composition of the blood, like, for example, anemic blood versus polycythemic blood. So there is so many things that can determine the amount of blood flow across a typical narrowing. So what your answer should be? The pink tetralogies have adequate good pulmonary blood flow.
Yeah, some people even say that probably there may be a developmental abnormality of the distal pulmonary circulation in patient who was deeply blue compared to, probably the obstruction maybe beyond the pulmonary valve level. There could be, that is another thing people keep.
But those are mostly given by people who are not operating on people, because then the surgery should not leave it like. There has to be some problem in surgery, and we don't find it. If you find a good correction, if you find a good BT shunt, and invariably the saturation improve. That is why I know some of the examiners talk like this, but then that's why I didn't include that.
Well, that is very fine. So there's one thing which is very clear that, by definition, the stenosis is always severe. And it's only dependent on the pulmonary blood flow, which is influenced by various factors. There are many other questions also you are asked. Topic continuous murmurs, as Dr. Rama said. What are the types of collateral? Then what are the types of ECG? You see in top, which we'll be covering in next class. So I think overall you've got a very beautiful and wonderful practical approach to a case of a cyanotic congenital heart disease and what are the commonly asked questions. And I would strongly suggest that you must listen to this particular talk again and again read that particular this particular topic from various books and try to make your own notes, and so that you are able to revise and re-revise these things in the end. Also recommended is that one of the guidelines that Rama sir in his last lecture mentioned, I remember last year, that so there is one follow-up guidelines, operative guidelines, how these patients should be followed up. That is also one of the things that he himself also is very commonly asking in the exams. And I would strongly recommend that you should all remember those guidelines which have been published by the society. So overall, thank you so much, Dr. Rama. It's been a terrific lecture. There's no doubt. And we'll be coming with the part 2 of this particular topic very soon. I'll be announcing after taking a suitable time for from Dr. Ramakrishanan. And thank you so much. Thank you, Intas, for providing us this platform. I will be posting this particular talk on the channel. You can listen to this particular talk. You can download it and revise and re-revise it. Thank you so much again, sir, for joining us on this wonderful platform. Stay safe and have a wonderful, wonderful weekend. We'll catch up next week with another talk. Thank you so much, sir. Thank you. Thank you so much.
Thank you, sir. Thank you.
Thank you, Sumut. Thank you. Thanks a lot. Thank you, Mohit.